discuss together. Right, so as we get into the didactic presentation, just to remind everyone of the echo etiquette, please keep your microphones muted until you're given an opportunity to speak. And if you have a question during the process of, while the didactic presentation is being given, go ahead and put it in the chat box. At an appointed time, we will ask you to submit, rather we will read your question. And also, if you have, you know, a response or a reaction, put it in the chat box or pen it down. At the end of the session, we'll give you an opportunity to raise a hand and ask your question directly. So at this point, allow me to ask Dr. Nteeni to take us through the presentation for today.
Okay, so once again, thank you so much again. So thank you so much again for the opportunity to share with all of us. So like has been introduced, we will now continue on to look at TB and the X-ray. And this was our basic outline. So we looked at the first two, I think the first one really, and then today we'll delve into the second and the third objectives. And then of course our outline was as put out there. We handled 1, 2, 3. Today we are going to look at 4 and 5. So without wasting much time, let's delve into it. So we all have had patients with TB. Some of us have had TB itself. I know for a fact that when I was in grade 11, 12, I was diagnosed with TB. I remember that I went to the hospital and I was just given I did my X-ray. I had this cough for a few weeks, and then the doctor didn't even take any samples or sputum or anything. She just looked at the X-ray and scolded me. What were you doing all this time? Put this boy on TB. And for that time we were taking, I think that was for 9 months. Should have been 9 months, yeah? That was 9 months before we now have these new regimes for 6 months. So one or the other, most of us have had this contact with TB. Now, when we come to TB and X-ray, we know that on X-ray, TB is what is known as a great mimicker. It can really mimic any other disease, really. And so the clinical data should not be ignored. And of course, with that, the previous images and the clinical information must be put together. Do not read an X-ray, not only for TB, but generally, don't read especially chest X-ray, don't read it without clinical information before you. It's important for you to go back, ask these the pertinent issues concerning this patient. When did this happen? Is it an acute? Is it chronic? Are there previous images? All that clinical data must be available to you so that you make an objective report or an objective diagnosis. And of course, we know that some of the resolutions on TB may take some of the resolutions on TB on X-ray may take weeks to months, and some of them actually will never. And we'll look at some of these examples as we move on. So we know that TB can be basically put into 2 phases. We know primary TB versus secondary TB. Sometimes we call it post-primary TB. So let's briefly look at what primary TB is. This is seen in patients who have not been exposed to the Mycobacterium tuberculosis, and it's most commonly seen in infants and children, and it has the highest prevalence in children who are 5 years and below. In most cases, it's self-limiting, and really, especially in children, its appearance is often indistinguishable from that of bacterial pneumonia. And of course, chest X-ray remains the mainstay in terms of imaging, and we find that in 15%, the X-rays actually come out normal. Okay, how does primary TB manifest? It manifests in 4 patterns. The first one is in parenchymal, lymphadenopathy, miliary opacities, and pleural effusions. Okay, so quickly we will look at some of these patterns. So pulmonary parenchymal disease. Okay, so you can have either consolidation in any of the lobes. Okay, and of note is that for primary TB, it really affects mostly the lower and the mid lobe. And if you see this in an adult and with the clinical pattern all together, tied together, you might want to consider primary TB. Okay, so can you distinguish it easily from bacterial pneumonia? It's quite difficult. So some of the things that you want to look for are nodes. If you see that you have some hilar nodes together with these consolidations, it points towards primary TB. And of course, if you give empirical antibiotics and the patient remains unresponsive, you might want to consider that as your diagnosis. And then sometimes in 60% of cases, some of these parenchymal foci may resolve completely. And these resolutions can take up to 2 years for them to completely resolve. And if they do persist, there is what is known as a gone focus that can be seen. This is just basically a previously parenchymal focus now, which has become sort of calcified. Okay, and if it's a bit larger, you find that these masses, which we call tuberculomas, may be seen in these patients in primary TB. Okay, so these are just examples of just trying to show us some of these consolidations. And remember, we went through these patterns. So once we see this X-ray, you're supposed to identify the pattern which is there. And of course, of note for our purpose here, you can see that there's a large consolidation right in that right lower or right mid to lower zone. Then the next pattern that we see in primary TB is mediastinal lymphadenopathy. It can be the only finding that we see, and in up to it is found in up to 96% of children and 43% are found in adults. And it's typically unilateral, and for some reason, most of the times you find it on the right side. And sometimes if these nodes are large enough, you'll be able to find you'll be able to see necrotic centers within. So you can see on this image here, we have these hilar nodes, okay? And to differentiate these, just follow, they will appear a bit lobulated, and you will see their abrupt cutoff. Differentiate this from vessels. Just try to look carefully. You see that if there are vessels, or if it's an enlarged vessel, it will still start dividing off into the various branches. But if you see no division, as we can see here, that tells you that this is a lymph node there. Then the other pattern on primary TB is a miliary picture. We all know about this. We've all seen miliary TB before. So they can be they may begin small, and in most cases of the same size. Okay, and in 1 to 7% with all forms can be seen with all forms of TB, and we usually see these cases in the elderly, in the infants, and those who are immunocompromised. So the last one is that of pleural effusion. And remember, we looked at these patterns, and we're not just now packaging it in terms of TB. We now know how pleural effusion will look like.
Mr. Daniel Nkandela, please keep your microphone muted.
So we all know how pleural effusion will look like. Here we can see the meniscal sign there, and you can see this opacity on the left lower mid to lower zone there. And this can complicate, of course, into a pyema, fistulae. Sometimes it can even erode the bone, the adjacent bone. And after treatment, you find that the pleura in that region becomes quite thickened, and it might even undergo some calcification. You see that, you definitely think TB would have had its footprint in that patient. Okay, so that is about primary TB. How about post-primary TB or secondary TB, which we now see which is common in adolescents and typically in adults? And of course, this can be because of reinfection or reactivation of TB, of latent TB. So the features of primary and post-primary TB may overlap, but of note is that when you look at secondary TB or post-primary TB, it has a predilection for the upper lobes, unlike primary where we said it's mid and lower lobes. And of course, if you don't see lymph nodes, you might want to think of post-primary TB. Not that you cannot have lymph nodes in secondary TB, you can have, but really lymph nodes are mostly seen in the primary TB. You see cavitations, these are most linked to post-primary TB. And these also manifest as parenchymal disease, airway involvement, or pleural extension. And obviously, they will appear similar to what we've just presented, the patterns which we have already outlined there. And of course, we just go through some of these patterns in the parenchymal nodes. In the as for parenchymal pattern, we spoke about reticulonodular opacities, okay, which as a pattern. So here, if you see that pattern in the upper apical region or in the upper zones, as can be seen here, and also these suggest of TB, and these are in most cases, these are the earliest signs that are seen on X-ray. If you see some of these parenchymal lesions in the apical and posterior segments of the upper lobes, that is suggestive of TB. Okay, these are also just trying to demonstrate some of these patterns that we see. I'm sure most of us now can recognize this pattern here, and we can see that there is a consolidation right there. Okay, in the upper zone with some nodules surrounding surrounding nodules there. Okay, so for secondary primary TB, just clearly look at the posterior segments of the upper lobe, and also the superior segment of the lower lobes. And remember, we spoke about the fact that the lower lobe goes all the way up here. So when we say lower lobe, don't always think of the lower part. Even somewhere there, that could still be a lower lobe. And this, when you look at the CT scan, there is what is known as a tree in bud pattern, which comes out very nicely. We see that with the clinical history, it's like a slam dunk diagnosis of TB. But of course, the lab tests will need to follow. Okay, so you can have these reticulonodular opacity. Sometimes they can become very coarse, as can be seen in this example here. We see these coarse reticulonodular densities in this lower lung as a lower lung zone as a result of post-primary TB. Okay, and this is just a CT scan, just trying to show that tree in bud pattern that I was trying to talk about. Okay, again, when you see this pattern, by now we should be able to recognize the various parts that we can see the patterns. Okay, at least we can appreciate some reticulonodular opacities, and of course we can see an area of consolidation here with some air bronchograms, and here predominantly we can see these reticulonodular opacities almost confluencing and almost forming more or less like a consolidation. Okay, so again, this is just trying to illustrate the region of opacity in this left upper zone there, trying to just highlight some of the things that we are talking about. Okay. Then the other thing which comes out, especially in secondary TB, is that of cavitations. And we can see here in the upper lobe, we have this area of consolidation, and we can see that within that area of consolidation, there is this air-filled space that is seen. It is seen as an area of lucency or low attenuation within a consolidation. Okay, and when we see these things in the upper zone, these are in most very highly suspicious of TB. Okay, and of note is that these cavities, even after treatment, these cavities may persist. So that's why we always want to say that we need to find a way of putting images in our system, like a PAC system, and storing images so that we are able to compare easily with previous images. Otherwise, you find that patients come back, they have this sort of cavity without that information that this patient had a cavity before, when the doctor puts that patient already on TB, because I mean, you look at X-ray, there's a cavity, etc., etc. This is TB, but when you go back to the history, you only to find that there was a very large, thick walled cavity. Patient underwent some treatment, and this now persists. Okay, so that is not active TB; it's just a residue cavity that probably is there. So the clinical now pattern, the clinical information should guide whether you put this patient on TB or not just the X-ray. Okay. So then, of course, you can have some lymph nodes, but I say that these are mostly seen in the primary TB, but it's not unusual to find also in post-primary TB having the patients having lymph nodes either in both hilar or on one side. Okay, this is just trying to illustrate that sometimes you can have these lymph nodes. It's a similar image we had. And of note here, we can see that remember we talked about the paratracheal stripe, which is supposed to be very thin.
All right. Sorry, we were muted for a few seconds.
So I was saying that you can see that there's this pattern here. We have these lymph nodes, both the hilar and also in the right paratracheal stripe there. A classic sign. Think about sarcoidosis. Think about TB when you see such kind of pattern. Okay. Sometimes secondary TB will also have its effect on bronchial stenosis. Okay, and these will lead to either lobar collapse or hyperinflation with obstructive pneumonia and mucoid impaction. And you may see this kind of involvement in 10 to 40% of patients who present with active secondary TB. And of course, when you do a CT scan, you'll be able to see this some of the twin bud opacities as a result of that airway involvement of the TB. And in advanced cases, you have this fibrosis happening, and then the bronchi or the bronchioles become quite dilated, what we call a bronchiectasis. Okay, then the other, just like primary TB, secondary TB, we can also have it affecting the pleura. Okay, we have a pleural effusion, which occurs in about 18% of cases, and mostly it's on the lateral, and we can see it as we already described last week, blunting of cosophrenic angles or a meniscal sign, or indeed, if it is quite large, you can have a complete whiteout of that hemidiaphragm. And of course, if it's that large, you'll be able to see the mediastinum shifted towards the contralateral side. Okay. Then, of course, you can have even after treatment, you might have the effusion resolving, but you might end up with a very thickened pleura. Sometimes that can, if the effusion is quite infected, you might end up having an empyema, which will complicate into a bronchopleural fistula. And post-treatment, like has been said already, you can have the pleura undergoing some calcification there. Okay, so the summary slide here, just trying to show how one can differentiate active from inactive TB. So this is quite a loaded slide there, which we can have time to go through, and you'll be able to, if you are faced with a pattern, you recognize that pattern, see what is there, and try to see, is this Am I dealing with an active TB, or am I dealing with something that has already happened? And then this is the footprint of TB. And of course, there is inconsistent pulmonary findings, which all of these things really you have to marry with the clinical that you have before you. And of course, I'll talk about this a bit more when I talk about the post-treatment changes that one may see. Okay.
Right. So before we get deeper into the conversation, we've seen in the chat box that there are a number of individuals that are saying they have no audio. So if you are unable to hear us, I don't know how we'll get, but then for those that are struggling, we'll put comments in the chat box on how to go about it. Thank you.
Yes. Can somebody confirm that they can hear us?
Yes.
Okay.
Yeah.
Okay. All right. So I just put this slide there, just trying to look at the fact that when TB is quite a mimicker of many lung diseases. So how would you go about it? Firstly, look at the pattern. What pattern am I looking at? And we've talked about this. Am I looking at a consolidation? Am I looking at node? Is it a mass? Is it a lung collapse? Am I looking at a reticular pattern? Okay, identify that pattern. Start from there. And then, secondly, which part of the lung is involved? Is it the upper zones, mid zones, or lower zones? Okay. Then, of course, what other things are happening in this patient? Okay. On radiology, look at is there any highlight involvement? Are there lymph nodes? Then in the clinical data, try to look at the fact that are there other organs that are affected? How is the lab work? Are there any previous images, etc., etc.? So that will help narrow your differentials so that you can rule in or rule out TB. And just to look at an example of how one can approach that is this slide here. You can see that the TB can present like any of these. Okay, so how will you be able to differentiate this? Really, is looking at the clinical findings. Don't just look at an X-ray. Find out when the duration of these symptoms. What are they related to? Is there chest pain? All these things can really make you narrow down the differentials. So don't rush into just looking at the X-ray. Please look at the clinical. Okay. So after the patient has had primary or secondary TB, there are changes that can occur in that patient, and sometimes, like we said, these changes can resolve completely, but some of the changes can be actually permanent, and there's that aspect where pulmonologist has to come in to start now managing that issue, what is known as a destroyed lung as a result of TB. Instead of putting these patients on TB all the time, there should be other options for managing these patients. Okay, so the facts are that the post-TB sequelae are alarmingly high, and treating TB itself is not the end. It should manage the complications that arise as a result of TB. Okay, of course, it has this psychosocial and financial impact. Okay, and some of these changes can cause an obstructive pattern on spirometry, but also mixed patterns have been shown, and also that gives us a rationale for how why we should not just look at antibiotic treatment, but also pulmonary rehabilitation for these patients. And it's important to be aware of the full spectrum of these disorders to facilitate early diagnosis, and we manage these patients. Okay, so some of these patterns, some of the categories that can be seen in these treatment changes are seen here. It could be parenchymal, airway, pleural, vascular, or mediastinal. So quickly, we just go through some of these patterns. And of note here, just trying to show us that fibrosis is by far takes the lead there. And of course, we have cavitations that can be seen, and then calcification and bronchiectasis down there. Okay, so some of the parenchymal changes that can occur, as has been said, is an entity called a tuberculoma, which we have already seen. This can be seen either in primary or post-primary TB, but in most cases you find them in primary TB. These are basically just round soft tissue densities, difficult to see on X-ray, but very nicely seen on CT. They can be solitary or multiple, with a wide range of sizes ranging from a few millimeters to more than 4 centimeters. And of note is that they usually have a smooth margin, and they'll have some areas of calcification. You see that it's just a tuberculoma as a result of previous TB. So here is just an example of an X-ray showing this well-defined nodule there. Okay, a zoomed in image just now shows it in better there. Okay, on CT, as you can see, on CT it just comes out very nice. Sometimes it's very difficult to differentiate this from a lung malignancy, because sometimes lung malignancies can actually be smooth wall, and they can show a benign kind of picture. So if the clinical is not tying, there is always warrant to go ahead and do a biopsy if you really need to be clear. But if the clinical tells this patient had TB and all that, that lesion can be followed up, and then a decision can be made. Okay, then so I said we have these cavities that can occur, and then after treatment you have they resolve, so they become very quite thin walled. All right. So the wall of a chronic cavity varies from 1 millimeter to about 1 centimeter thickness, and it may be quite smooth. Sometimes it's difficult to distinguish true cavities from bullaces and pneumatocells. You see these things very nicely on CT. But here we have these examples of these thin-walled cavities as a result of this patient who had TB. Okay, as I said, so you have these cavitatory lesions post-primary, post-secondary TB seen on CT. So then there's an entity called cicatrization, or basically scar formation, which is just a combination of parenchyma and airway involvement as a result of the scar formation. Just like any other part of your body, you hurt yourself, the body starts healing itself, a scar forms. Even in the lung, you have that aspect happening where you have scar forming, and this can be part of the lung, which is completely affected, okay? And in most cases, this is seen as an area of alveolar destruction with loss of the lung volume, and then, of course, the ipsilateral mediastinal shift. In other words, the mediastinum shifts towards that side which is affected, okay? And in most cases, it's one-sided, and once that lung is destroyed, it's hard to rule out active disease. And again, I can't emphasize this more. You go to the clinical to rule out active TB. So here we have an example. You can see that there is complete collapse of the left lung there, and the mediastinum the heart is supposed to end here, but you can see that the heart has shifted towards that area. And now this is basically footprints of previous TB. There is no evidence of active TB in this case. You don't see any proof. You don't see these reticulonodular opacities. You don't see these clear active indications of TB. But can we rule it out? The answer is no. We cannot rule it out. We need to look at the clinical and make sure that we don't rule out an underlying active TB in these patients. And the other thing that can happen with these cavities is that an aspergilloma or a fungus can colonize that cavity, okay? And we can have this super infection. And so you find these patients are having these clinical symptoms, and patients are being put on TB, and forgetting that actually we can have a fungal infection that can be responsible for those chest symptoms. So here is just an example of this soft tissue, sort of soft tissue density lesion on X-ray seen here in this cavity. Okay, so sometimes in rare cases, patients can develop bronchogenic carcinoma from a previous tubercular scar. Okay, this is quite rare, but you find that patients can actually, you can have, that scar can be a nidus for patients having bronchogenic carcinoma. So this is just trying to show an X-rays of this patient who had previous TB, and then he has now developed a large mass. And doing PET-CT, and in follow-up, we find that it was actually diagnosed as bronchogenic carcinoma. Okay, so the other thing that can happen in the airway. So the main thing that happens there is bronchiectasis, which is common finding in post-TB sequelae, and it occurs due to destruction and fibrosis of the lung parenchyma. And then there is what is known, there is irreversible secondary bronchodilation, and it can occur both with primary and secondary exposure. And when you see this happening in the upper lobes or upper zones, it is highly suggestive of it being of tuberculous origin. So this is just a CT and X-ray trying to demonstrate these dilated bronchioles or bronchioles, okay, in the upper zone there. Similarly, we can see that these are quite dilated bronchioles. Remember, TB can also affect the mid and apical zones of the lower lobe. So if you see these quite dilated bronchioles. Okay, so you can also have tracheobronchial stenosis as a result of those granulomatous changes in the tracheobronchial wall or extrinsic pressure from an enlarged peribronchial lymph nodes. And this may start as a simple edema and then subsequently progress to fibrosis with narrowing of the tracheobronchial diameter. For some reason, the left main bronchus is frequently affected. Then tracheobronchial wall thickening with enhancement and enlarged adjacent mediastinal nodes, common findings best seen on CT rather than on the radiograph. So what you might just see on a radiograph is collapse. So that's why we talked about collapse of the lung, how you identify a collapsed lung. So you should be able to identify in this image here, what pattern am I seeing here? And you can see that this is the right mid and lower lobe collapse. Okay, so apart from that, you can also have stones that can lodge into one of the bronchioles. So you can have these calcified nodes, and then they seep themselves away and then go into the adjacent bronchiole. But to be honest, to see it on X-ray, it could be a challenge. There could be some things that can help you to see it, but really when you do a CT scan, these calcifications come out quite well. But it's something that we should be able to know. Then of course, lastly, you can have this pleura that you have the pleural thickening and calcifications. Okay, so tuberculous pleuritis usually resolves completely even in the absence of treatment, but the chronic complications occur during the healing of TB lesions or appear as late sequelae such as pleural thickening and pleural calcifications. It is usually asymptomatic, but may also present with discomfort when the patient is trying to breathe. Okay, so here we just have these examples of radiographs trying to demonstrate this pleural thickening and calcifications. It can be quite extensive as being seen here. So when you see these things, please try not to overcall. This could just be previous TB footprints. Active disease should be ruled out clinically. Okay, so some of the complications that you can have with when you have this pleural effusion, you can have this empyema that may form. Okay, best again, you can see it on CT. It has these signs that one you can actually call it as an empyema. On X-ray, you just see a very large effusion there, persistent effusion, antibiotic treatment, and all that, and it's right there. And sometimes this can complicate, and you might end up having a bronchofistula, okay, and this air collecting within, or rather pass connecting into the airways. Then, of course, in some cases, you can have an pneumothorax developing as a result of a patient having TB, and we already looked at how one can identify a pneumothorax. And we can see the nicely demarcation between the lung, the air here, and also the collapsed lung there. So sometimes you can also have these vascular complications that can occur as a result of TB and of what is known as Rasmussen's aneurysm. Okay, this now we treat it using interventional radiology. Okay. So again, basically, when you're talking of TB, when the footprints of TB in essentially in almost all the parts of the body are calcifications. Whether you're talking of TB involving the ureter, TB involving the psoas muscles, you find some. If you see calcifications in that area where there was some infection, that is suggestive really that you might be dealing with that. TB infection there. So similarly, we can have these calcified lymph nodes that one may see in TB. Okay, so you can also have an entity called fibrosing mediastinitis, which is basically caused by an excessive fibrosis within the mediastinum, and this has its own differential diagnosis, but one of them is TB. When there's extensive fibrosis as a result of a patient having had TB, you might want to consider fibrosing mediastinitis. And of course, when you do a CT scan, you might see how that is happening and the encasement of these vascular structures, which might even cause a spiravena cava syndrome. Okay, so you can also have the TB going towards the pericardium or TB pericarditis. But for our purpose, maybe it's beyond, so that we just know, since we are limiting ourselves to the lungs. All right, so this is what how we can approach TB. Try to identify the pattern that you have. Try to see whether this is primary or secondary TB, and then try to look out: is it is it a sequel of TB, or is it actually is it truly a true active TB? So the main summary key points here are that TB can mimic other diseases, and it's important for us to identify a pattern of disease and tie it with its clinical history. Then the key point number 2 I put out there is that post-TB changes should not be confused with current TB infection. Please, again, clinical is key. Please don't ignore the clinical. All right. So this is essentially the end of our discussion. It has been a quick one, and so that we leave room for my other colleagues to come in and say one or two things.
Right. Thank you so much, Dr. Nteeni, and indeed, it's very interesting conversation that we've had so far. And already I can see that some of the questions that were asked in the previous session about how you differentiate active TB from previous TB infections have been dealt with, and we've discussed various patterns that are characteristic of TB. From cavitations, consolidations, reticular disease, lymphadenopathy, some changes in terms of the anatomy. We've now talked about the fact that TB can also cause a pericardial effusion, and various things that can occur on a chest, which you can pick up on a chest radiograph. And like was mentioned, TB is a great mimicker. And so we have to marry our clinical acumen with what we're seeing on a chest X-ray, because ultimately what we treat are patients, not radiographs. So with that said, are there any questions regarding the presentation so far?
So we have some cases, we can go through some afterwards.
Are there any comments, questions on what has been presented so far? So after this, we'll go through some cases. There's some X-rays where we'll then try and compare, could this be TB or not? And Dr. Nteeni will lead us on that. But for now, are there any comments or questions, or was it a very clear presentation up to this point? Okay, in the chat box, I'm seeing various people were saying they had audio issues, but I think our team has ably dealt with that. And there's also requests for the presentations to be shared. These are going to be shared on the iEcho database. So you do well to register using the links that are being shared in the chat box now. And you will have access to these presentations, and you will also be given, you will be able to download a certificate of attendance, which you will then use for your CPD points, whether GNC, HPCZ, or whichever professional body you are subscribed to. Right. Any questions? No comments? All right, so there's a question to say, how do you differentiate pleural thickening from lung collapse? That's a very good question. How do you differentiate pleural thickening from lung collapse? And Dr. Nteeni, you agree that's a very interesting question, because we saw in the previous discussion how atelectasis will appear as linear densities on a chest radiograph. And so if it's very proximal to the chest wall, how would you tell that is it pleural thickening or atelectasis? And then there's a comment saying the presentation was very clear, just a matter of going through the notes. Thank you for that feedback. We will provide you with the notes. Maybe you could speak to the question on the difference.
Okay, I think as we go through the various cases, we'll tackle it.
All right, so as we go through the cases, we're going to tackle that particular question. There's a hand from Mutukwa Muyango. Mutukwa, please go ahead with your comment or contribution or question. Mutukwa. All right, the hand has gone down.
Accident.
All right, so there's a question again from Ruth Zulu, who's asking, how do you tell previous TB changes from current infection? I think as we go through the cases, we'll still emphasize on that. Okay, so allow me to hand it back to Dr. Nteeni so that we can go through the cases and discuss a bit more with examples.
Okay, so for those who are sleeping, please welcome back. If you can just look through on the what is projecting there, I would like feedback from anyone just to tell us what they see. We won't look at the technical technical issues. They could be there, but for now, let's just concentrate on the pathological issues. What pathology are we seeing there? Anyone?
All right. Any volunteer to try and give it a shot? You can marry the lessons from last week and what we've learned today to describe what you're seeing on X-ray. So you could just go ahead and unmute and give us your submission.
Let's see anyone I know.
Good
No, please go ahead.
Yeah, the X-ray on the right looks like it has the cavitary lesion mid-zone near the hilar region. Then the one on the left has consolidations in the lower zone bilaterally with some
We'll go with that response for now and build up on what you said. Laston, please go ahead, Laston.
Yes, no.
And
I just wanted also just to give a comment on the two X-rays. Just to start with the one on the left, I can see that the left diaphragm, it's kind of pushed up, if I'm not mistaken, because I'm not able to appreciate the left-sided costophrenic angle as I'm able to appreciate it on the right. Then
left side or right side?
Pardon?
Is it
the right side? Sorry, the right side. Yeah.
Okay.
Yeah. Then I think the X-ray on my right. I'm able to appreciate the costophrenic angles on both sides. Maybe just a comment on the middle lobe on the right. There's some kind of density which I'm able to see just there. It could be not very sure what it is, but it looks like well defined kind of density, which looks like it has got some kind of lucency inside it. Yeah.
Okay.
I think
So
that's my comment.
Go for it. Call it. What is it? You've described it well, but call it. What is it?
Oh.
What name are we giving it? I think it has been mentioned by Philip. It's a cavity, isn't it? So we have that's a cavity right there. Then, like as has been said, there are some airspace filtration, like a consolidative process going on there, and also there. And then of course it's a pleural effusion that is there. Okay, so so there are a number of things that can cause you to have cavities. Okay, so one aspect of this presentation was trying to how are we to differentiate TB from other infections? You need to be able to marry all these things with the clinical and be able to pull up those differentials. So just by seeing a cavity, one shouldn't call that as TB. There are other things that can cause TB, and this is a pneumonic cavity. And you can see it's a loaded slide there, right from things that are cancerous to things that are congenital or more or less congenital. Okay, so you need to be able to absorb this slide and narrow your differentials accordingly. Okay, so how about this case? Can somebody just quickly tell me what's going on in this image? This is a 75-year-old lady who presents with worsening cough. What is happening in this image? Does this patient have TB? Can somebody say something about this? If you're presented with this.
all right, any takers? You could simply unmute your microphone and give it a shot. Start by describing what you're seeing before you can tell us what you think the pathology is. I had seen Brigitte had unmuted the microphone. Would you like to give it a try? All right.
So you don't be...
Right, there's an attempt from Dr. Hamuza. Please go ahead.
Yeah, I can see a mediastinal shift to the right.
Yes.
So probably would think about some scarring on that side as our facilitator guided us earlier. So there is scarring on the right, probably causing that shift in the mediastinum to the right side.
What else is giving it away that there could be some scarring? So there's mediastinal shift. One. What are the other two things that one can look for? In fact, three things that we can see in this X-ray. So mediastinal shift. We don't see anything happening in this side to account for this mediastinal shift. So we assume that there's some loss, isn't it? So it's a volume loss this side. So mediastinal shift, volume loss. You can see that this lung is quite large, but this side, there's loss of volume. The third thing, what could it be? If you follow this, it's making more of a tenting of the diaphragm there. It's the same thing, trying to show that there's some area of volume loss that is happening in this region. And of course, you have the collapsed right upper lobe there. So yes, you're right. This is just basically scarring. And of course, sorry, I forgot to mention the trachea. The trachea has been pulled, isn't it? So it has also been pulled towards that side. So there's some evidence, all those things tied together shows that there's some scarring that is happening here. Okay. Is there anything else that we can see in this image that is not related to TB at all? If I was to make you into radiologists now, anything non-TB related? It is not this, it is not this, it is not this, something else. You were looking at this, forget about this, this and that. What else can you say? It's an old lady, that's a hint. She lives in America. She wanted to be beautiful when she was young. All those are giveaway, no?
Can I say something?
Yes, go for it.
There are silicone implants.
Yeah.
Perfect. Yeah. I hope everyone has seen those implants, isn't it? These ones. Yeah.
Yes.
Yeah, perfect.
Right. So, Doc, before we leave that image, there's something interesting that I've also noticed when we're looking at interpretation of chest X-ray. Who can give us a thought? What do we think about the rotation in this image? And how can it affect our interpretation, especially when we're talking about mediastinal shift? Any takers?
May I give it a try?
Yes, please go ahead.
Yes, this is Dr. Mwanza. So if you look at this X-ray, the right medial end of the clavicle looks lower than the left one. So it's slightly rotated to the left.
To the left or to the right?
To the right.
The right, right?
It's rotated to the right, yes.
Okay, two people think it's rotated to the right. So those that say it's rotated to the right are correct. And you can see the medial end of the left clavicle is almost at the level of the midline, but then the medial end of the right clavicle is, a few centimeters away from the midline. So which means that this X-ray was rotated to the right. And obviously it might give you an impression that there's a significant mediastinal shift. And, so as you are looking at that when you're interpreting a chest radiograph, have that in mind, because structures may appear to have shifted, but the positioning of the patient may not have been very adequate. So this shift, rotation in this radiograph, plus the partial collapse that we're seeing, sort of magnify the problem, probably the extent much larger than what it actually is. Absolutely. So we need to think around that each time we're reading a radiograph. Right, thanks, Doc. We can...
Next one, you can go ahead.
Right, so we have this one. What do we think is going on in this image? Again, let's start by giving a brief description of what we're seeing, before we jump at the pathology that is screaming at you. Any takers? Okay. Please, anyone willing to give it a shot? Or what abnormality are we seeing here?
We are having the obliteration of the cardiac shadow. It is not well defined. We are having multiple opacities in both sides, left and right. And again, on this one, there is a slight loss of volume on the right as compared to the left. I think in terms of description, that's what I can see.
All right. So what do you think is going on in this patient?
Looks like something chronic. Looks like something chronic affecting the perihilar region. Perhaps.
Why are you saying the hilar region? There's an important point you have put out there. The hilar region. What is it about the hilar region that is giving away this case? So you said that there's something going on there, isn't it? Both sides. Plus, you mentioned the fact that this lung volume is reduced, but what else? What else is giving it away in the hilar region? You can see that we are supposed to see the vessels coming down in this region, but everything has been pulled up. Are you seeing that? So both hilar have been pulled up. So something has pulled the hilar region. I mean the hilar structures up, making them almost straight, instead of the way they are supposed to appear. So that tells you that there's something going on which is chronic, and of course, to just say it out, that is scar. What that term we said, cacitrization or scar collapse, okay, of both sides, more which we can see on the right side. So this was an X-ray. We're just trying to demonstrate that this is an X-ray of a patient who has these respiratory problems, but it's not because of an active infection per se, but it's because of that scarration that has happened as a result of that chronic infection, chronic sequelae of the previous infection. Okay, so scar can bring issues. So you might be able to read up more on that. There's an aspect of phrenic nerve, but you just read that up. Next, this one.
So we have this image. Ignore the blue dot. I'm sure someone will be saying that's the problem. Ignore the blue dot in the middle of the image. What are your thoughts? Anyone to give it a try? Describing and probably highlighting what the abnormalities are. Otherwise, feel free. There are no right or wrong answers. We are all learning one from another. And where we go in the wrong direction, or rather a little bit deviated from the truth, we have the experts here to bring us back to the right direction. And just remember that, the more you try to speak these things, focalizing them, it's easier to remember the concepts. So we have this radiograph. Let's start it this way. Was this X-ray taken in AP or PA? Anyone who would shout out whether it's AP or PA?
I think that's AP, sir.
Okay, so you think that is AP? Anyone thinks otherwise? Or maybe I didn't see the name clearly. Was it Godfrey or Geoffrey? Why do you think it's AP? Is it posterior anterior or anterior posterior? All right, so while we're waiting for the response, who can tell us, is this in inspiration or expiration? You could put your answers in the chat box as well. Okay.
But it would be nice if you say something.
Right.
Who do you pick on here?
Kawewe has said it's inspiration. Would you like to speak to why you said it's inspiration? That answer is correct, by the way. Why do you think it's inspiration?
Kawewe, unmute yourself. Sorry to put you on the spot, but don't worry.
The lungs, they have the full volume of lungs. Yes, that's what I can appreciate from that X-ray.
Yeah. So you have a full volume of the lungs, and then of course we need to count the ribs, isn't it? When we count the posterior ribs are supposed to be how many? So there's an objective way of knowing that there's good inspiration, right? So when we count the ribs, anterior ribs are supposed to be like 5, 6. Posterior ribs are supposed to be like 8, 9. And as you have said, it appears very full like that because all posterior we can actually count 8 to 9 ribs, 8 to 10 ribs. You can nicely see them there. But Kawewe, when you look at this X-ray, go zone by zone. What do you think is happening here? You've ditched us. Ruth Zulu, are you brave enough to unmute yourself?
Yes, sir.
Yes.
I can see that the upper lobe of the right lung has an opacity.
Yes.
Yes.
How would you describe? Is it triangular? Is it rectangular? Is it circular? What? How would you describe that? What shape is it making?
It's triangular.
Triangular. The next question you want to ask: how is the lung volume on that side? On that side of where that is? Yes.
Where the lesion is, the lung volume is reduced.
Okay. Then the next question you're going to ask yourself: are there some linear lines inside this opacity? Am I seeing like what we say are air bronchograms? Am I seeing these linear strands traversing this opacity? So when you ask that question, what do you think the answer to that? Are they there?
I can't appreciate them.
Perfect. So no air bronchograms. The reduced lung volume that side. What is the diagnosis of this one? You've given all the right answers. Now you just need to hit the has put the answer there. It's atelectasis of the right upper lobe. So you have this triangular plastic, okay? Thank you so much,
sir.
Ruth.
Thank you, sir.
There was a hand from Mubanga. Mubanga, would you like to add your comment or question to the conversation?
No, thank you. It has been covered. I just wanted to give an answer to the diagnosis on the X-ray, but it has been mentioned.
Okay, stay on the line. Here we are. Mubanga. Being put on the spot, no?
Right. So anyone who would like to give it a shot, what are we seeing on this radiograph? Right, Mubanga, you're still on. I see you are unmuted. Any thoughts? What's your take?
And don't be under pressure at all. We're just relaxed. We are just having coffee or something. We're just seated. So just look at this X-ray, and then just divide it into 3 zones. Look at the upper zone, compare to this side, compare to this side, and just start saying what you're seeing without looking at the diagnosis per se. Just say just read it, read the X-ray. Okay, let's start with the heart. Okay, when you look at the heart, we say that the right border is bound by what? This side, the right atrium, right? Is Mubanga there, or am I talking to?
I'm here. I'm listening.
Okay, how are the borders on the right side? Are they sharp? Are they obliterated? Are you able to see them? Are you happy with the borders on the right?
Yes, it's quite visible, unlike the left part.
Perfect. So basically, we can't see the left side, isn't it?
Yes.
Yeah. Okay. At least we have that one. We've banked something in our books. Left heart border is not clearly seen. Then what else? When you compare this lung to this other one, which one is bigger? Is there any aspect of volume loss?
I think a bit the
would you like to give a comment?
Yeah.
All right. Maybe Edith, if you could continue.
Okay. So Edith, what you were saying something about the lung volume. So just compare the right side and the left side.
Yes. So the left side, of course, the left side usually looks smaller than the right, but it's quite smaller than usual.
Okay, so you're saying that there's loss of lung, there's loss of lung volume on the left, isn't it?
Yes, especially you are looking at the left diaphragm there. It's quite lifted up than normal.
Perfect. So we have banked 2 things. One, the left heart border is not seen properly. 2, there's also lung volume loss there. So basically, when you hear lung volume, you're thinking of a collapse, isn't it? So when you say lung volume, you're thinking of a collapse. Now, the question that you're now trying to ask yourself, what has collapsed? Am I dealing? You're on the left side, so you're just dealing with the upper lobe or lower lobe. So you're thinking, am I thinking of a left upper lobe collapse or left lower lobe collapse? What do you think? Is it the upper lobe or left lower lobe?
It's the lower lobe.
What are the giveaway texts for that?
The fact that the diaphragm has been pushed up.
Okay. So actually, when the diaphragm there's a tenting, so there's no real tenting per se of the hemidiaphragm, but we agree there's loss of lung volume. But if you are to follow this hemidiaphragm, you will follow it all the way, and it is still seen all the way until you reach the spine, isn't it?
Yes.
And then yes. So then also when you see that the aorta, you can see the aorta nicely there.
Mm-hmm.
The shadow is clean. Okay. When you see those 2 things, then you rule out lower lobe collapse. So what you're now dealing with is the upper lobe collapse, actually. So it's quite a tricky thing, because it might make you think that it's actually lower lobe, but it's actually a left upper lobe. And remember, we talked about these intersecting themselves like when you look at it on a radiograph. So when you see like a veiling of the left heart border, it's like a veil, like something, like a curtain has been put over it, okay, on the left hemidiaphragm there. Then, but then we can see this, you can see nice, you are dealing with classic left upper lobe collapse. So that is actually left upper lobe collapse. And we can try to look at this hilar region there. There's something going on there, right? You can, so this is suggesting this could either be a lymph node or a mass actually that has compressed that bronchus that is going towards that left upper lobe. So lymph node or a mass. All right. So well done. I don't know if you want to carry on.
I wanted to ask something before you move.
Yeah.
What's your comment on the left costophrenic angle area there? I can't appreciate the costophrenic angle. To me, it looks like part of the lung on the left area there is not, it's either there is pleural effusion or something. Maybe I would like to hear your comments there. Just where the cursor is down there. If we compare the right and the left, there's a difference in the costophrenic angle area there.
Okay, so yeah, we can see that it's supposed to be very sharp, isn't it? Like more like a beak of a bird, nicely there. But we can't see it as well. But we can see that there's also some area, that aspect of lower lobe collapse, which has brought it a little bit out. So I of course, it appears like it's blunted a bit, like maybe it's possible that there can be a small pleural effusion, but really, to me, it appears quite sharp. I wouldn't call it pleural effusion on this. I would pass it as if it is there, it could be quite minimal. Okay, so that's a good pick. It's possible it could be minimal, but I would actually pass it. Okay.
All right.
Right. So let's have someone give it an attempt. I see there's someone called Lupon. Lupon, you could give us your thoughts on the X-ray on the screen now. Okay, Lupon has gone. Anyone who would like to give it a try? We have this radiograph on the screen with various abnormalities, some more obvious than others. Any thoughts? Anyone who would like to give it a try as we are getting to the last few minutes of the session today? All right, any comments?
Anyone can unmute themselves and I'll guide you through, no issues, don't worry. Just unmute yourself and then I'll be guiding you along if you so wish. Just unmute yourself and I'll guide you step by step, don't worry.
Through the chair.
Yes, please.
Well, I can see that it was done in PA.
PA, perfect.
First of all. Secondly, it was in full inspiration. I can see I can count the anterior ribs. I can count at least 8.
Okay.
Then from the upper lung zone, I can see there's some tracheal deviation to the right. Then hello, are we together?
Yes, we are following close.
Then in the middle lung zone on the right, I can see there are some opacifications. The right cardiac border is not clearly defined, so there's some silhouetting of the right cardiac border all the way into the right lower lung zone. Then the right hemidiaphragm is also tented.
Okay.
Yes, and well, the
okay,
right.
Note, plus or minus, tempting. It looks like nicely. Okay, yeah. Okay, we can say maybe plus or minus, but let's pass it. Let's pass it like it's a nice dome. Okay, so continue.
I can see both costophrenic angles, both right and left.
Okay.
But then there's also some increased opacifications around the perihilar regions, both on the right and left. Otherwise, I think that's where I can end.
Okay, so what is the overwhelming, or is do you have a diagnosis just based on that? Because what I got from you, what is strongly coming out is that there's that trachea which has been moved this side. Okay, then also you're saying that there's silhouetting of this right heart border there. So what is going through your mind?
There can be loss of lung volume on the right.
Okay, yeah. So there's like loss of lung. That's fine. So you're saying that there's a collapse?
Yes, it could be a lung collapse on the right lung, but I'm not sure which zone it is exactly.
That was my question now. So, we have three lobes, isn't it? This side. It can only be upper lobe. We have an example of an upper lobe collapse where it forms like a wedge-shaped triangular area. So upper lobe is out, okay, for now. So we are remaining with middle lobe and lower lobe. Okay, so which lobe would be affected? Or is it both? The lower lobe and the middle lobe? Or if you were to pick one, which one would you pick?
I think I would pick the middle lobe.
Why?
I think there are more opacifications around the middle lobe than the lower lobe.
Okay, yeah, that's fine. But so there's this sign that you mentioned, where the heart border is not seen.
Oh, yes, yes.
Once you see that heart border is silhouetting the terms you used, you are actually telling us that there's something going on in the middle lobe. So like if you're on a phone and you're telling me that the way you were mentioning, in my head, I was already thinking this is a middle lobe that he's talking about. Okay, so those terms that you were mentioning, silhouetting of the right heart border, okay, that you are just basically saying there's something in the middle lobe. And remember, the right lower lobe, sometimes when it's collapsed, those vessels do not come out, but you can see that some vessels there. But in any case, when we do the lateral radiograph, it comes out nicely to confirm the collapsed middle lobe. Okay, so well done. Do you want to take another one? We have, I don't know.
No. I can give someone else a chance.
Let's see, I don't think. Okay, so I had some cases, but I think miliary TBs, they were quite nice cases actually, just that we don't have time. Oh, sorry. We don't have time, but the slides will be shared with you. And I've put out some of the salient features that you see on those radiographs, such that all by yourself you can read, and then you can look at what is being demonstrated. It has been a pleasure, and I just hope that it has been helpful to you, as it has been to me, as we are managing patients whom we are suspecting of having TB. Over to you, Dr. Singini.
Right. Thank you so much, Dr. Nteeni, for that very, very interesting session. So you will agree with me that there's a lot that we can actually talk about when it comes to tuberculosis and chest X-ray. And, you know, whatever we discussed from last week's session to today's session is really just the tip of the iceberg. You know, these kinds of trainings regarding chest X-ray interpretation, particularly in relation to TB, it takes 1 week of 5 hours a day discussing approaches to this. So really compressing it into 2 sessions was really a mammoth task, but I'm highly impressed by how Dr. Nteeni managed to actually, bring it out in a way that is easy to follow and understand. Again, if you have questions regarding this, please do not hesitate to reach out to us so that we talk a little bit more about what we have learned so far. We'll link you to the experts in case you need that opinion from the experts. So we have just about 3 or 4 minutes to wrap up. Just want to ask our subject matter experts also to add in a voice on what has been discussed so far. I saw Dr. Chitalu Chanda on the call. Doc, any remarks regarding the conversation so far?
Okay, as Dr. Chitalu is trying to come in, there was that question. I don't know if I told through these exercises, it has answered the question on terms of collapse. So I was trying to deliberately talk about how one can differentiate collapse from other issues. So the pleural thickening, you'll be able to see it as a very thin peripheral thickening like that without any volume loss per se. But when you see volume loss, then you are now dealing with the atelectasis. So when you see there's no volume loss and there's that thinning, you probably are dealing with with that thickening, you might be dealing with the pleural thickening only and not associated with any collapse. It's possible you can have both. Okay, so you need to just look at that also.
Right. Thanks for that, Dr. Nteeni. Dr. Chitalu Chanda, any last remarks, comments on the presentation or anything that needs to come out from regarding chest X-ray interpretation? All right. I don't seem to see Dr. Chanda anymore. But colleagues, just to mention in brief, the third objective for today's session was regarding computer-aided diagnosis. So briefly, what this is all about is a computer software which, when you load a chest X-ray image, it will be able to pick out salient abnormalities on a chest radiograph and give you a score which determines the likelihood, whether there's a likelihood of TB or not. And mind you, I'm using likelihood and not saying it will give you a diagnosis of TB. It will just tell you the likelihood of having tuberculosis or not. And so for those that have worked on mobile tracks and those that are receiving digital X-ray units, they may have a software which may tell you that this could be TB. But please remember that that does not, give you a definitive diagnosis of TB. It merely increases your index of suspicion for TB. Marry the findings on CAD and the clinical findings to make a diagnosis of TB. And this is part of the conversation that started from last week's echo session. Now, a quick announcement is that a number of people have reached out to us regarding iEcho and struggling to register. So tomorrow there will be an onboarding session for those that are having challenges registering on iEcho. And so our coordinator, Eta, will share the links and the times when this onboarding will be done. And this will be done through the various WhatsApp platforms that we use for ECHO. Again, a number of people are asking when or how they will receive the presentation. This will be uploaded on the iEcho database, and so once you register on iEcho, you will receive these presentations together with the certificates which you will use for your CPT with HPCZ, GNC, or any other professional body you are affiliated to. So there was a question or a comment from Dr. Mikoloni regarding computer-aided diagnosis. I briefly hinted on that, but if there's something specific you'd like us to address regarding CAD, please go ahead and just unmute and ask your question in the last 3 minutes.
No, it's fine, Doc. For respect of time, I'll ask this time. Thank you.
Right. Thank you so much. So we will discuss with the rest of the ECHO task force that, we have maybe a repeat of this presentation next year as we make the curriculum. We'll consider having more of these conversations and also talk to the program people so that perhaps we could plan a 5-day or 3-day series just talking about radiological diagnosis of TB, so that we can have a bit more interaction. But as was mentioned, please do remember that these concepts become easier to comprehend the more you look at radiographs. So the more you look at radiographs, it will increase your bank of normal. And once you know what's normal, you will be able to pick out that which is abnormal. So with that said, we are signing out. Thank you for attending today's call. Bye-bye.
Thank you, Doc.
Thank you. Bye-bye.
Thank you.
Thank you, Doc. Wish we can have them every quarter.